Good afternoon. I would like to thank the organizing committee and especially to Professor Tatjana Stosic for inviting me to be with you. So the topic is how to do the MRI report in patients with epilepsy. As you know, the diagnostic yield of MRI depends on many factors, and we can summarize them in 4 main groups. These are the indications, which means what is the patient population we apply our imaging, the pathologies consistent with epilepsy, MRI techniques, protocols, and image quality, and of course, last but not least, expertise of the reader. I like this study because it summarizes the main information. If we apply the optimal protocol for epilepsy, and if the images are read by experts in terms of epilepsy imaging, radiologists, we can achieve more than 90% sensitivity of detection of focal lesion. But nowadays, the report is even more important, and this is because we perform the examinations in different hospitals by using different imaging protocols, and there is a possibility of communication errors with patients, with other physicians, and also we have to interpret imaging findings in terms of the clinical history. And I think that also one of the main our problem is working in these filmless departments where the communication is almost close to zero. So the learning objectives of this lecture are these main 3, and we will start with the first one. Is it possible to create and to use structure report in those patients? Okay, we start. So what is radiology report? I believe that almost all of you know that we can put the patient demographics, clinical information, what kind of procedure and materials we apply. Of course, the body is to report and to explain our imaging findings. It's good to make a comparison with the previous study, with the previous studies, if there is any. And it's good to give our final diagnosis or to make a list of differential diagnostic possibilities. As you know, in some of the patients, we can suggest the follow-up imaging. So what is the structure report? This is computer-generated itemized reporting, which has the consistently ordered sections, and it uses standardized language, and we have to have these templates or checklist to generate this report. This can also integrate the additional information in terms of annotations and also key images, which are quite important for our neurologists or neurosurgeons, because we can pick up, let's say, 5, 10 images out of 200 or more than 200 images. But you should remember that it doesn't increase the quality of the report. So the main positive things are connected with researching, teaching, and quality management. I like this systematic approach. This is the mnemonic one. So these are the places we have to look for, and by doing this, I hope that we will not miss any kind of pathology. So first, look for the size of the hippocampus and signal, then look for some signs of asymmetry, and if there is any, you can use your 3D T1 imaging and you can correct just thinking about the symmetry. Look for periventricular region, but also peripheral abnormalities. It is quite easy to detect obvious lesions. SAGE comes from sulcal morphological abnormalities, atrophy, gray matter thickening, and very rare condition. This is encephalocele of anterior temporal lobe, but it should also give the epilepsy. So what we can have in our daily practice is, it's good to have quite good clinical information and also EEG findings, which can lateralize. So they can they can provide us information that this is involve the right or the left hemisphere. But unfortunately, it happens that we can have MRI negative epilepsy. And also, we should be aware of the problem with dual pathology. Fortunately, we can apply this systematic approach. And by doing this, we can reveal even very, very small and subtle pathology. And it's good to make a structure report. This is an example of a 10-year-old boy with epilepsy. And I hope that this is quite obvious that this patient has increased signal and also decreased dimensions, decreased volume on the left hippocampal area. What about the dual pathology? Of course, we need more images. And if I show you these two, you are sure that this is the case with dual pathology. I hope you agree. Okay, but what happens in our daily routine? First, our eyes are caught by this, what is quite obvious, and there is a tendency to neglect hippocampal region. That's why we have to follow this mnemonic scheme, or you can create your own. But please, please look for hippocampal region. And this is another case. You see quite extensive multicystic abnormalities. This is a young baby with sequelae of hypoxic ischemic encephalopathy. And you can see also the atrophy, increased signal, malrotation of the both hippocampi. Of course, this is not only the hippocampal sclerosis which could affect this hippocampal region. This is an example of a young lady with low-grade tumor. Here we have an increased signal, but there is no signs of atrophy. And this is a man in his late 50s with proven, histologically proven lung carcinoma. So this is a very, very small ring-enhancing lesion, which was proven to be a small metastasis. Okay, so first, look for hippocampal abnormalities. What about periventricular region? This one is quite extensive. So I'm sure that nobody will miss. What about this one? This is quite small nodule, but if you follow this step approach, if you follow the scheme, you will never miss even such a small lesion. And with this slide, I want to illustrate that if you have a good clinician, if you have the clinician who provides you with a relevant clinical information, you can combine your imaging findings with the clinical history and you will get the diagnosis. Okay, so this is a small girl with mild spastic tetraplegia, dysarthria, dysphagia, epilepsy, and learning difficulties. You can see bilateral perisylvian polymicrogyria, and this is the sagittal image. And when you combine imaging findings with the clinical history, you can make a diagnosis of Forster-Drought syndrome. Okay, cortical and subcortical abnormalities. This is not only the cortical and white matter blurring, but this is also quite small, even smaller than this one. This is a small cavernoma. And you know that you can change, you can, practically you can tailor your protocol to the imaging findings. You can tailor the protocol to the particular patient. That's why you can apply SWI or T2 star, just to rule out the multiple cavernomas. Later I will show you one case. To summarize, our checklist can consist of hippocampus, developmental abnormalities, atrophy, subtle cortical abnormalities, and obvious lesion. only these 5. Again, hippocampus. For hippocampal sclerosis, first rule out any signs of asymmetry, and please do correction. And then look for the asymmetry in terms of the dimension, and also in terms of the signal intensity. You have to think about bilateral hippocampal atrophy and dual pathology. Developmental abnormalities. You can start with periventricular region and then move to the cortex and to look for the gray matter thickening, look for the pachygyria, polymicrogyria, and all other malformations. And also be careful with this transmatter sign and gray-white matter junction. In terms of atrophy, you should think not only for hippocampal atrophy or mesial temporal sclerosis, but you should think also for focal atrophy, or in case of hemiatrophy, you can apply the gadolinium if you face the patient with Sturge-Weber disease. Subtle cortical abnormalities, just look for gray white matter junction. If there is any even small calcifications or some other small lesions. Obvious lesions, mass effect or hemosiderin rim. This is easy to be detected. So, what is the medical legal value of our report? You have to know that as radiologists we are more vulnerable than other physicians, and the main cause is failure to diagnose and also the communication errors. Radiologist errors are reported to reach up to 30%, and 70% of them are perceptional. This is because we miss the abnormality, and only 30% are cognitive, because we misinterpret the abnormality. So why we are vulnerable? Because, as you know, the data is retrievable. And again, this problem with poor communication. And also because we have new equipment, new protocol, new techniques. And all this can lead to revealing of subtle pathology. What about the medical legal value of the report? This is a medical legal document, and this is the formal communication with the referring physician. So this is the official confidential document, which is the physical property of the hospital or doctor's office. And it serves as a database for planning for individual care of the patient, to justify the diagnosis, management, and treatment. Legally, a radiology report is important in a malpractice suit because it can be brought into the court. I know that maybe in your country, as in mine, it is not so common for the radiologist to go to court. Is it common or not? No? But you should be aware, because previously I was working in a private hospital for 4 years and a half. Fortunately, I was fortunate not to go to court, but some of my colleagues, they did. Okay, and since signing of the report, it becomes the integral part of the patient's medical record. This is an example of close to 60-year-old man, and this morning I was at Martina workshop. So this is follow-up after neurosurgery. Do you think that they succeed to remove this lesion? Okay, so it was the operation before of this cavernoma, and they claim that they remove. They show me the histology, but I see that this is here. And because there was a worsening in the course of the epilepsy of this patient, I have to perform this follow-up. So this is something what gone to the court, okay? And these are 2 different cases. It was reported in another hospital, and we perform another examination. So I give another opinion. It was reported as a right-sided hippocampal sclerosis, but this is the choroidal fissure cyst. Even they insist us to apply a contrast to be sure. This was the demand from the neurosurgeons. It happens also in my country that the neurologists or neurosurgeons can insist, can ask us to apply contrast. But it is not common in Austria, Maida. It never happens, or?
It happens.
It happens. Okay. Okay. And this is the case with bilateral hippocampal sclerosis. Actually, it was neglected because of the bilaterality of the lesion. And this is another example of young man with bilateral oliguria. So we know this abnormality, but neurosurgeons insist to perform the PET. And then we fuse these both images, and we have this PET MR, which was fused by using the software. We don't have this PET MR machine. We perform PET CT and MR and then fuse the images. Okay, so you can see this bilateral hypometabolism, which in other circumstances, which be the cause for epilepsy just because of the hypometabolism. But when we combine this finding, this decreased hypometabolism, with the morphological findings, we can be sure that the decrease is because the brain tissue is decreased in relation with the normal one. Again, the men at the same age, this was reported as normal. We perform the PET, we fuse the images, and we can detect the hypometabolism into left temporal region. Then we go back, and maybe because we have such an information, we can detect the blurring in this area. Okay, what is the importance of our follow-up report? It could be happen that the initial MRI can be negative, but on follow-up, we can have some structural changes. Maybe you have such a patient, and you know that in some of the patients, it takes time to develop hippocampal sclerosis. This is especially true in some of the genetic forms of epilepsy. That's why this structure report can help us to perform the follow-up in these MRI negative patients, but also to perform the dynamic evaluation of already known abnormality. What are the indications to perform the repeat MRI? I hope that almost all of you are familiar. I just summarized them. So in any case of pharmacoresistant epilepsy, when we plan surgery, this is the pre-surgical examination. In patients with seizures with poor control and normal MRI, we can put them on 3AT or perform the newer techniques. And in every child which is younger than 2-year-old, if we have some doubts and if we are not sure, it's good to repeat MRI at a later age, just to be sure that myelination is proper for the age of the patient and that everything with the cortex is normal. These three are the clinical indications to perform the repeat MRI: worsening of the seizure control, new neurological signs, or unexplained change in seizure characteristics. Of course, very common indication is to follow up what happens after the surgery. And these are the main three scenarios. This is the first one. The pathology can still be there. And this is the partial removal. Exactly, this is not the biopsy. This is quite big to be a biopsy. Or they can take away the whole pathology. And as you know, some of the conditions, for example, cavernoma or tuberous sclerosis, they should be followed up. This is the patient with tuberous sclerosis. You should rule out the conversion, the transition to the subependymal giant cell astrocytoma. And in such case, you should recommend this patient to visit the neurosurgeon. And this one is without any genetics behind. It is not the genetically proven multiple cavernoma. And this one is bleeding. So in case of cavernoma, you know that in some of the patients you can have acute bleeding. And this is the case given by Andrea Rossi. In patients with Rasmussen encephalitis, on follow-up you can see the dynamic. For example, this one was performed 1 year later than the first one, and you can see the increase of the signal in the area and also the shrinkage of the whole area. So, for conclusion, it could be helpful for you if you use this structure report, because you can reduce your errors, you can reduce your time for reporting, and hopefully will reduce the risk of medical legal problems. It will be helpful for you because a systematic approach can lead to detection of subtle pathologies, and you can follow up the patients. But some of the radiologists believe that structure report is not so good as the free text opinion, and the free text opinion will be best ever option. And I should remind you about the RSNA reporting initiative to developing a library of best practice radiology report templates. So I would like to thank you for your attention.